and we knew that palliative care is different than hospice care. We knew it wasn't an end-of-life engagement. It was, or from our perspective, a way to help us make decisions. And as we said, what can we do to make Ben's life most comfortable, make him more comfortable going forward as we make these decisions?
Yeah, the decisions we needed to make weren't, they were becoming larger and more complex and multifaceted, so we couldn't just make a decision about Ben's eating, because the ones we were making about that were now impacting, or just about his spine. It was a ripple effect, and we wanted to put all those medical doctors in the same room and ask them to do the same thing, to see how surgery would impact the GI system, how it would impact his neurology. Thank you. And so we needed help with that. And so we called Pat, and she came to our house, actually, which was great, because I think that setting is so much more comfortable.
It was actually such a perfect use of palliative care to essentially to create a space where you can examine what next steps are. And you two came already with a language about talking about Ben, a philosophy of care. You were very clear that you wanted to do those things that would help the quality of his life. You weren't necessarily looking to extend his life, and you certainly weren't looking to shorten his life, but the interventions being considered had to benefit him, had to be of a benefit. And I think we get so confusing as a medical profession when we say things like, well, he'll need a G-tube, because the need really is in the context of what's important. You may need a G-tube to live forever, but you may not need a G-tube to have the kind of life that you want to have.